Hematology from UKM in 2009. She has special interest in molecular hemato-oncology and has undergone training in this field in 2005 to 2016 in 2015 to 2016 at the University of Turin in Italy. Her main diagnostic interest is molecular diagnosis of hemato-onco diseases and has been actively involved in upgrading, conducting training and research in this area. In fact, today's webinar is one of her projects to educate and expand the service of BCR ABL1 quantitation. Now I would like to invite Dr. Siti Shara to give her talk on major BCR ABL1 quantitation in CML. Doctor, you may share your slides.
Assalamualaikum and good morning. Thank you for the kind introduction. Boleh nampak ke?
Boleh.
Boleh dengar ya? Okay.
Boleh.
Okay, my topic is major BCR ABL quantitation in CML. So I'm going to give brief overview of CML actually, because all the technical parts have been given by Sean and Puan Mahiran, and the case discussion is going to be given by Dr. Wee later. So I'm going to divide into two: brief introduction to CML, diagnostic, workup and treatment, and we go into the second part, which is BCR ABL P210 quantitation. And CML, myeloproliferative neoplasm.
Sorry, Doctor. I think your sound is a bit putus-putus macam tu.
Putus ya?
A bit putus.
Tak boleh dengar.
Dia boleh dengar tapi dia macam putus-putus like that.
Dia tak smooth.
Dia tak smooth. Macam mana ya saya dekat... Saya cuba sekali lagi ya. CML is a myeloproliferative neoplasm with an incidence of 1 to 2 cases per 1,000 adults. Boleh ke? Ke putus-putus juga?
Macam breaking ayo. Tak smooth.
Macam breaking ya. Macam mana saya dekat... Macam mana ya? Mana?
While waiting, we have Dr. Nick Hafiza, is it? Dr. Nick, you have anything to ask? Dr. Nick raised her hand.
I think it's the internet problem lah. So how? I tried to log in using my handphone and see how. And can we proceed with the next presentation first, or we want to continue with this while I sort the technical problem? Up to you.
There's a few questions in the chat box. Maybe I'll proceed with that first. Is that okay with you, Dr. Shahrul?
Boleh. Saya cuba off camera. Better ke?
Okay.
Better ke saya punya sound? Ke still breaking?
Sama ayo.
Sama.
Dia breaking tapi boleh lagi lah.
Okay, while waiting for Dr. Sharon, we have one question from Dr. Ayuni to Mr. Sean. Can you clarify why the assay can't be used for monitoring after discontinuation? How about using the assay for monitoring treatment-free remission patient? And I think Mr. Sean has also replied. Cepheid only submitted treatment monitoring as intended use to FDA or CE when they registered the test. So technically speaking, monitoring after discontinuation and monitoring TFR patients may not be suitable due to limitation in RT-PCR technology. Patients might be having deep molecular response and PCR tests might not be able to detect very low percentage of the IS percentage, and SAFE is still waiting for guidelines from NCCN regarding this issue. And then Dr. Ayuni also asked, should we put any disclaimer if we have to use it for TFR patient while awaiting the NCCN guidelines? Mr. Sean, do you have any recommendation for this?
Okay, so for the disclaimer side, I can check. I think I need to check with Safid whether they regarding the TFR and the patients patient after discontinuation of DKI. I need to double check whether we can put a disclaimer for that.
Okay.
So I'll get back to you again, Dr. Ayuni, on this.
Okay, thank you.
Thank you.
And then we have another question from Dr. Lai, Hospital Umum Sarawak. Would like to know how to determine the acceptable fold difference for each level of C130 IS panel. And Puan Mahiran did answer in the chat group. For acceptable fold difference for each level, NCCN guidelines support a threefold range from the mean value for the acceptable criterion used for the expert BCR ABL ultra assay analytical studies, as I have shown in the slide for MMQCIIS value. So, Dr. Lai, does that answer your question? So we have no more question from the chat box. Dr. Sharul?
Okay, is it better now?
I think it's still the same, but still boleh dengar lah. I rasa boleh dengar. A little bit
Boleh dengar,
putus-putus, but
A bit
acceptable lah.
putus-putus.
Uh-uh.
Mana mama punya handphone?
Boleh dengar, dia cuma bunyi runut-runut saja.
Kejap. If I use my handphone now, is it better?
Kejap mama, it's not in the phone. Mama tutup ni, tutup kejap. Ni, ni, tutup my phone.
Hello? If I use my handphone, is it better?
Yeah, it's very smooth now.
Better?
Yeah, thank you.
Okay. I'll continue. Okay. CML is a Sekejap ya, saya kena.
Alright, should be okay.
Is it okay now? Ada bergema, nanti saya kena volume. Better? I think it's better now.
Yeah, yes, very much better now.
Sorry about that. Again, CML is myeloproliferative neoplasm with incidence of 1 to 2 cases per 1,000 adults. 50% of new diagnosed cases of leukemia in adults is categorized by Philadelphia chromosome, which Sean has mentioned before, described in 1960 by Peter Nowell and David Hungerford, and is the first recurrent chromosome associated with a human malignancy that has been discovered. And this is, again, the reciprocal translocation from the BCR ABL here, long arm, to the short arm, to the long arm of the BCR long arm to the ABL, is the translocation from the ABL chromosome 9 to the BCR at the chromosome 22 and result in BCR ABL fusion here. And this encode chimeric BCR ABL protein with deregulated protein kinase activity. This is the primary driver mutation in the formation of CML. And here we have reciprocal translocation. What is it? Actually is ABL
The slide
BCR,
doesn't move.
meaning it's happened at this expressed in approximately 70% of CML patients not believed to play a role in the disease process. And we know that 95% of CML patients can be detected genetically, meaning we can do cytogenetic testing, but 1 to 5% of the patients have fusion gene which is scripted, so only can be detected with FISH and PCR. That's why we still do FISH and PCR at our workup. And this is the schematic view of them at molecular level. We see this is ABL gene at chromosome 9. The breakpoint is quite constant actually. It is at the A2 and A3. One is translocated. If it's translocated as this region, this is E13, E14, we get major BCR ABL.
Sorry for the technical issue. Give us a few minutes to solve this. I'm sorry, Doctor. Dr. Sharun got cut off. She will relog in.
Reciprocal translocation between long arms chromosome at chromosome 9 here. Here it goes to the chromosome 22, result in fusion gene BCR ABL, and this one encode the deregulated tyrosine kinase activity. This is the primary driver for CML, and this can be detected by cytogenetic in 95% of CML patients, but remaining 1 to 5% they have cryptic fusion gene, so it can be detected with FISH or PCR only. And this is the reciprocal translocation, just the previous slide, sorry. Expressed in approximately 70% of CML patients not believed to play a role in the disease process. Next slide. This is the schematic view of the at molecular level. If we have a look, the chromosome 9, the breakpoint is quite constant. It occurs at A2 or A3. So if it's translocated to this region, to A3 or A14, E13, E14, we're going to get the major BCR ABL, which is typical breakpoint that occurs in 98% of the patient. It can be E14A2, E13A2, but majority is E14A2, 10% expressed, both isoforms. This is atypical BCR ABL fusion, is 20% of the BCR ABL, and the most common are E1A2. This is the most common. Ideally, if we want to do a BCR ABL qualitative diagnosis, we have to do this molecular that can cover most of the breakpoint here. Next slide. And diagnostic workup, of course, morphology, FBP, bone marrow, cytogenetic, FISH, and molecular. And guidelines is from ELN 2023, 2020, and WHO, of course, our WHO. For morphology, the next slide. Why morphology is important? Bone marrow aspirate is required for morphology assessment. The proportion of blood cells and basophil is important to distinguish chronic phase from accelerated phase and blast phase. It's also used for cytogenetic testings, and core biopsy may be done to evaluate the degree of fibrosis, which has prognostic importance and may identify nest of blast not evident in the aspirate. I just want to, next slide, the update of WHO classification. The designation of accelerated phase has become less relevant and omitted in the current classification, emphasized on high-risk features associated with CP progression, such as additional cytogenetic abnormalities, resistant to TKI, and development of blast phase. Next slide. This is the recommendation, ELN recommendation, the test that can be done during the follow-up, during the diagnostic. And the first one is cytogenetic, mandatory for all CML cases, interface phase, recommended for initial screening, detect all BCR ABL rearrangements irrespective of breakpoint, but it doesn't differentiate what breakpoint. Qualitative RT-PCR recommended for initial screening, determine BCR ABL transcript type. That's why it's important. Mandatory to detect atypical BCR ABL variants as well. And if it's blast phase, CML in blast phase, we can do NGS panel for myeloid and lymphoid. Next slide. Cytogenetic along with FISH and or RT-PCR should be used in all cases to confirm a diagnosis of CML. The limitation of each approach as standalone tests need to be understood and where appropriate included in the clinical reports. Cytogenetic testing should include a screen for additional cytogenetic abnormalities at diagnosis. This is from ELN 2023 recommendation. Next slide. BCR ABL mRNA transcript type should be determined for all cases prior to treatment to enable appropriate follow-up. This one we do BCR ABL qualitative. The possibility of rare BCR-able variant should be excluded. If testing for rare variants is not available, the diagnostic report should clearly state that the presence of BCR-able remains a possibility and that further testing in appropriate reference laboratory should be performed. At the moment, at HTA, we cover most of the common atypical, but some rare atypical we still cannot detect actually. Next slide. This is PCR, just a brief review, RNA extraction, and then we convert to cDNA. And this at HTA, at the moment, we use endpoint, we use PCR, run gel, and this is the gel that we interpret later. But later on, we're going to change into real-time. Real-time PCR, continuous fluorescent measurement of PCR product using each cycle of PCR, and we analyze data. It's still detected or not detected. It's not quantification. This one we're going to do. We're going to change to this test later on. Next one. Next slide. This is example that we do for information for our what we do in HTA at the moment. This is if we see 1, 2, 3, 5 cases, and each cases we have 2 tubes. And this the first line is 6B. It detects the P110, P10, and P230. And the second tube, 8F, detect the P190. We look at the first case. 6B is positive, so it's around 400, just below 500. The next slide. The next slide. So this is below 500. We look at here. Below 500, it is 472, meaning is major BCR B3A2. And if we look at the second and third cases, the base pair is similar, just before 400. So we look here, the second and third cases are B2A2, major BCR-able. And the last case is the positivity is at the 8F. So 8F, we look at this table. Table is provided actually with the kit and is just after 300. So next slide is 320. 320. This one is the P190. And the next one is normal, because this one is the control, reaction control applicant. It must be positive to control RNA quality and functionality of the test. If it's not present, the test is not valid. Next slide. Treatment. Why treatment? To improve survival so that it matches that of a normal population. The secondary aim to achieve a durable DMR, which can then allow treatment discontinuation and potentially a TFR status. Next slide. These are the 4 TKI that has been approved for frontline CML therapy: imatinib, dasatinib, nilotinib, and bosutinib. All 4 produce near normal quality of life and life expectancy, provided patient comply with the treatment, monitored optimally with minimal interruptions in therapy, managed appropriately at the earliest sign of true treatment resistance. Our role here is to monitoring. So we are going to provide monitoring by providing BCR-able quantitation. The second generation TKI may produce earlier DMR, deep molecular response, hence reducing the time to reaching a TFR. Next slide. Monitoring of measurable residual disease. Guideline, actually, we based on these 2 major guidelines, ELN, European, and NCCN, US. And they describe the roles of cytogenetic, RT-qPCR, and BCR-able TKD mutations. But now we are going to focus on the RT-qPCR. Next slide. This is the recommended monitoring by ELN. This is wajib, mandatory for routine molecular monitoring. Quantitative RT-qPCR. Cytogenetic suggested at overt hematological relapse, failure according to LN, or suspected overt disease progression. considered in cases in remission but abnormal full blood count. BCR-able TKD mutations strongly recommended in cases who fail to reach defined ELN milestones or loss of MMR on TKI therapy. If our colleague asks what is the test that possible, these are the tests which is recommended by ELN. The next slide. Patients expressing atypical BCR-able fusion should be monitored by bespoke or patient-specific validated RT-qPCR or RT digital PCR assays and result expressed as individual molecular response compared to the baseline pre-treatment level, meaning they have to do the pre-treatment and then the monitoring. It's not like that we are doing now. We don't do the pre-treatment. We just do at 6 months and every 6 months. So result cannot be expressed and international scale, and thus standard time dependent molecular milestone and guideline for treatment discontinuation cannot be applied. So this one is special case, which is about 2% of CML cases. And FISH is not recommended as this technique has very limited sensitivity compared to the molecular monitoring, but it may be useful in molecular tests for atypical fusions are not available. Meaning this one, if patient have atypical fusions, BCR-able atypical fusion breakpoint, so cannot monitor with our standard kit BCR-able quantification, they need to use FISH because we don't have patient-specific validated RT-qPCR or RT digital PCR at the moment. Next slide. The NCCN mentioned about the same actually. Next slide. We know we have to do PCR quantification, but how often? According to ELN, qPCR on blood cells expressed as BCR-able percentage in RS according to international scale perform at least every 3 months forever, even after an MMR is achieved and confirmed, because close monitoring of molecular response is required to assess eligibility for treatment discontinuation, which is TFR, which I'm going to describe briefly, discuss later. And NCCN 2020, they do molecular BCR-able quantification at diagnosis. We don't do. And they do every 3 months after starting treatment until BCR-able less than equal 1% IS is achieved. Then every 3 months for 2 years and every 3 to 6 months thereafter. For us, before we start the service, we discuss with a head of clinical hematologists, and because of the resources limitation, budget, staff, we agree to do every 6 months. Next slide. So we have, we know that we do 6 slides, and this is how are we doing at the moment. HTA, HSA, JB, HPP, we do for tender, the national tender, 6 monthly and allow special requests. Recently, we add yearly once patient have achieved DMR, deep molecular response, MR 4 and above because of limitation of resources as well. HSA, JB, they do at 3 and 6 months after starting the TKI, then every 6 months subsequently allow special requests. And they also add yearly for some stable patients with undetected or below level of quantitation. HPP maintain with 6 monthly. Melaka, QH, ESTA, they do on your own. They have their own, they purchase on their own. Melaka, QH, 6 monthly and allow special requests. ESTA, 6 monthly, and they have TFR patient, then, and so that they do monthly for 6 months for these patients. Next one, next slide. This is new centers. The purpose of this webinar actually, we welcome HTJ, Hoshas, cover East Coast, HSB, Stanabahia, Kedah. Actually, they sent the sample to HTA, but after the tender finished in August, we're not going to accept the sample already. So they're going to do the test on their own. And then we have additional 2 centers here, Permaisuri Bainon, Ipoh, and HUS. Actually, HUS has started recently because they cannot send sample to Ampang already. And congratulations to HUS, they have started already. Next slide. What is BCR-able P210 quantification? Actually, we use PCR assay, use peripheral blood. And this is gold standard for monitoring in CML. Regular testing provides essential information required to make timely important treatment decisions, such as whether to continue current TKI or switch to a different TKI or alternative therapy. The other purpose is to initiate a period of treatment-free remission to patients who have achieved a sustained deep molecular response on TKI treatment. Next slide. To ensure accurate BCR testing, this is the ELN 2023 recommendation. Laboratories should participate in standardization external quality assessment programs. We have UKNICAS, establish conversion factor, or use calibrated kits. We use calibrated kits. Validate the assay is capable of detecting MR 4.5 in most patient samples. This one is being validated by the company, but we do verification using the control. Okay, next slide. MRD analysis for CML should use ABL, BCR, or gas beta as internal reference gene, and we use ABL1 for our Genexpert. Expressed in international scale, yes, and measure for E13A2, E14A2. That is what we are measuring. For assessment of deep molecular response, test should be optimized to achieve a limit of detection of 4.5 or better using clinical samples. And regarding the question, this one, according to this, any test which can achieve limit of detection of 4.4 can be used to assess deep molecular response. So whether it can be used for discontinuation is not in the recommendation. I have to look further. We need ongoing IQC to monitor assay stability over time. Next slide. The methods, I just briefly go through available methods. This is RQ-PCR. Data can be rapidly obtained by real-time detection of fluorescent signals during PCR cycling. First of all, we have to do RNA extraction, and then we convert to cDNA, and then we do PCR. And then this is the faster the graph reach the threshold, meaning more BCR-able available. So this line at the far right, the sample is very minimum because it reached the threshold level after so many cycles. And as real-time detection, relative quantification, quantitative assay with standard curve. And I want to mention about the concept of one step and two step because somebody asked actually. The one step meaning, the two step meaning we do conversion to cDNA using another PCR, the normal thermocycler, and you load. After that, you have cDNA, you put the primer and everything, and then you load into the qPCR machine. But one step procedure is you prepare PCR into the RNA and then mix together, and you load into the qPCR, meaning the conversions to cDNA and the amplification and quantification is done under the same platform. The next one, next slide. Sequential, this is ELN recommendation. Sequential molecular monitoring of CML patients by RT-qPCR has been established for many years to assess the depth of clinical response to TKI or identify early relapse after stem cell transplantation, meaning we can use the test for patient on TKI or patient post-transplantation. Level of BCR-able mRNA in peripheral blood leukocyte from patients on treatment serve as a surrogate for disease burden and strongly correlate with the clinical outcome. And the next one is RT digital PCR is an acceptable alternative to RT-qPCR and may offer some technical advantages, particularly for assessment of very low-level disease. If this method is well validated, well optimized, actually is more sensitive than RT-qPCR. Next slide. I just share this is the old version. We have droplet generator, droplet reader. RNA is separated into numerous small volume compartments here, the partitioning part. Each compartment has 0, 1 or many molecules. And once we do PCR here, the circle one here, after amplification, the absorbance in each compartment is counted. The bottom one is negative partition, and this one is the positive one. Digital PCR is endpoint detection, absolute quantification, quantitative assay as well. Next slide. This is the new one. This is the automated one. This is because somebody, I believe this is in the circulation. Somebody has approached you, and I just briefly explain to you. This is automated, but we need RNA extraction first. It doesn't start with blood sample. You need RNA extraction. You have to do RNA extraction, whether it's manually or automated. This RNA extraction, the RNA sample, you use make a PCR primer, and then this is the final volume. Load into this cartridge and load into this machine. Amplification and interpretation occurs here, meaning it's automated. Use cartridge here. One-step PCR which perform reverse transcription and real-time PCR continuously. Absolute quantification without standard curve. Detect BCR-able fusion transcript type E13A2 and or E14A2, the major breakpoint. Next slide. This is the one that this webinar is all about. I just highlight the salient point. IVD, quantitation of BCR-able, and the ABI MR transcript, because we use ABR, this is the reference gene, and detect E13A2, E14A2, use preferred blood specimen, fully automated. This one, it doesn't need RNA extraction first. We just do minimal minimal procedure, red cell lysis. It depends whether you are expert or not, maybe 15 minutes to 30 minutes for red cell lysis. And add wash reagent and sample to the cartridge here, and then load the cartridge into the Genexpert system. At HTA, we have 4 slots. RNA extraction, reverse transcription, and fully nested real-time PCR or BCR-able target gene and ABL reference gene is done in fully automated in one cartridge. So this method, we don't need to do RNA extraction. Next one. Next slide. This is according to ELN. Previous one. Use of automated sense. Previous one. Use of automated. This one. Sorry. Use of automated sensitive RT-qPCR system for measuring BCR-able on the international scale, such as the Cepheid Genexpert Ultra mentioned in the ELN recommendation, or RS calibrated RT-qPCR or RTD digital PCR kits validated to detect deep molecular response, is often considered preferable to the complex and expensive process of in-house method development, validation, and calibration to the international scale. Meaning some centers, big centers, they still use in-house BCR-able quantification. The validation is very difficult, but we use the calibrated method, so it's less. We just do verification. The Genexpert system is particularly useful in resource-poor settings, but is also widely used in developed countries. So it's very suitable for us with lack of staff. Next slide. When we say molecular response, what is it actually? Should be reported according to the international scale as the ratio of BCR-able that we are measuring against reference gene expression transcript, meaning we measure sum of BCR-able if you do duplicate, divide by sum of reference gene, time 100 and time conversion factor. This is how you calculate, but this one we don't have to do because Genexpert give the RF value already. RS value. What is RS? International scale. International scale define MRD level as a percentage relative to the standardized baseline used in the IRIS trial in 23 and not to the pre-treatment level of each patient. That's why we don't need pre-treatment level. And then the number of reference gene. The reference gene is the 3-1 ABL, BCR-able, GAS beta. in the same volume of cDNA used to test for BCR-ABL indicate the sensitivity for that particular sample. I will describe later. And this is if we have 0.1 is MR3, 0.01% is MR4, 0.001% is MR5. This is deep molecular response. This is major molecular response. Next slide. How to get the CF? We don't have to get it. We don't have to do anything because we use kit. So the conversion factor is provided for us, and in fact is calculated already for us. But for other centers who use in-house, they can use sample exchange with an established reference laboratory or secondary reference reagent calibrated to the first WHO International Genetic Reference Panel for the quantitation of BCR-ABL. Next slide. This is the sensitivity. If we look at the undetectable disease, I think it's easier. Undetectable disease, if your ABL is only 10,000, you can say patient have achieved MR4. But if undetectable disease, but your ABL copy number is more than 32,000, you can say the patient have achieved MR 4.5. So meaning the copy number of the reference gene that determine how sensitive your test it is. But for Genexpert, it doesn't matter. We don't have to look at this copy number anymore. If you use another kit, you have to look at the RS, you have to look at the ABL copy number, and then you have to interpret on your own. But for the Genexpert, the result is only valid if the ABL copy number is more than 32,000. Regardless of the sample, the sensitivity of the test is always reach MR 4.5. The MR of the patient is determined by the international scale level only. Okay, next slide. This is the correlation MR 1 log reduction, international scale 10% is complete hematological response, log reduction 2, 1% is complete cytogenetic response, log reduction 3 log reduction, RS 0.1% is MR3. Next slide. This is the milestone from ELN 2020. I just want to highlight because during reporting, because we do at 6 months, we don't expect the patient to reach MR molecular response at 6 months. So you don't have to comment whether the patient have achieved molecular response or not. You just give the RS value. At 6 months, if the patient does not achieve 0.1, you can say does not achieve MR3 of the patient achieve molecular response before but now lost it. You mentioned patient has lost major molecular response. That's why this milestone is important. Next one. Technical consideration for the one who's going to start the services. This is from ELN 2023 as well. Anticoagulated, not heparin basal, peripheral blood samples, adequate volume 4 to 5 mils. For us, we use 4 mils. The test use 4 mils and delivered to the testing laboratory as soon as possible, ideally within 24 hours and no later than 48 hours, and processed within 72 hours. RNA should be extracted from total leukocyte, not mononuclear cells or any other cell fraction. Next one. Next.
No way, blah, blah, blah.
Difference in RT-qPCR amplification efficiency may result in distortion of the estimated disease burden at both high and low levels. Amplification efficiencies can easily be checked over time using plasmid that harbor both BCR-ABL and reference gene targets. Example, ERN AD623. This is example only. We can use any other calibrators. Laboratories should measure the variability of the test and include this information in clinical reports, so treating physicians are informed of the uncertainty of measurement. at clinical decision point. Next slide. I just briefly mention about treatment-free remission. It is safe and feasible in patients with durable deep molecular response, meaning they stop the treatment and once they achieve the deep molecular response, they stop the treatment. They only monitor the BCR-ABL quantification. The patient has to be CML-CP chronic phase on TKI for at least 3 years, have stable prolonged deep molecular response for 4 or 4.5 for at least 2 years. And we say here from the study, we know that if it's a DMR for 2 years, 3 years CFR rate is 4 to 50%, but DMR more or equal to 5 years, better TFR rate, which is more than 80%. So at the moment, in the absence of severe toxicities, most CML experts and patients are leaning towards continuing the TKI therapy for longer durations before considering stopping. Why this is important, TFR, and approximately 50% of patients who attempt to discontinue TKI therapy after achieving a stable DMR remain in a TFR after 5 years. So this one avoid the patient to be on prolonged TKI treatment because some of the patients actually they're quite young. Next slide. Why this is important for us? Because we have to do more frequent monitoring. This one is a 2 guideline again, ELN. This is Europe way of doing things. Monthly for the first 6 months, every 2 months for 2 months for months 6 to 12 months, every 3 months thereafter. But American way, monthly monitoring is during the first year of discontinuation when the risk of molecular relapse is highest at first year, every 6 weeks during the second year, every 12 weeks beyond that. This is, I think, during discussion with clinical hematologists, we follow ELN guideline because it's less stringent. Next slide. And this is our sample requirement, our handbook, our test, blood, ADTA. We need 5 to 6 ml because we need 1 ml for full blood count because of the reason that Sean has mentioned before. Fresh sample packed in ice, transport immediately at 2 to 8 degree. Make sure ice is not placed directly on the samples. Sample should reach HTA within 48 hours. Ensure the date and time of sampling is clearly written in the request form. Test is not less than 6 months. Last test is not less than 6 months. Never freeze specimen and protect from extreme heat. We use the normal pipette form office hour only, and the TAT for us is 9 days. Next slide. You can skip this one. Next slide. This is next slide. This is our usual request form. Next slide. What is required? Date of diagnosis, starting treatment, last test. Diagnosis because we want to know whether it's 6 months already or 1 year already, so that the reporting is different. Last test because we want to know whether it's 6 month lapse or not, because we just do 6 monthly. If they want to do 3 monthly, they have to speak to us. Any recent treatment interruption like pregnancy. So if there's any changes in the result, we know what's the result. Patient on TFR, if frequency of monitoring is different, they have to tell us, so that because it's monthly, it's not 6 monthly. Last BCR-ABL quantitation results so that we can compare. If the last BCR-ABL result was in molecular response MR4, MR5, 4.5, sorry, and this one is lost major molecular response. So we have to inform the clinician. That's why we need to know the last result. If first test transcript variant type is required to avoid false negative result. This one is important because I come across actually my experience. The send BCR-ABL quantification was negative, but the complaint that fish was positive. And I asked what is the breakpoint. True enough, it was atypical. Of course, it cannot be detected. We cannot use our kit to monitor CML with atypical breakpoint. And then that one we have to use fish. Next one. Next slide. Daughter's name is not available. Next one. no date of sample taken. This one is important. So because we want to know whether sample is stable or not, we have to do the test within 72 hours of blood taking. That's why this one is important. Next one, next slide. Next slide. This is how it looks like. The negative, this is the printout. If it's positive, it's color in red. Next slide. If it's negative, it's green. So we know straight away. But if you print in black and white, you don't know. It's all black and white. The next one. This one, I think Sean has gone through earlier. Can next slide. This is ABL pass, ABL transcript detected CT within the valid range. ABL pass, ABL pass. This is the result. Where is ABL pass? Here. CT within the valid range 10 to 18. Endpoint is more threshold setting to 100. ABL endogenous control normalize the BCR target and ensure sufficient sample is used in the test. Next slide. Probe check pass or probe check result pass, verify reagent rehydration. This is the probe check result. We have to make sure it's passed before we can interpret. What it does actually, it verify reagent rehydration, PCR tube filling, or reaction components, probe and dyes are present and functional. Next slide. Laboratory report according to reporting of CML in UK in 2018, ideally should have transcript variant type. We don't have it. Line of therapy, we know, we put in our result reported in RS only. Yes. Reference gene use, we use ABL1 but we don't put in our result yet. Technical details such as the level of sensitivity, we put in this, we have in disclaimer. Both the actual BCR-able result RS and MMR we do include in our report. Next one. The laboratory should promptly notify the clinician when there is a marked changes in BCR-able level and or when a change in monitoring frequency is required. Is available. Mutation status and time of at which the mutation was first detected should be included. Timing of the test, list of graph, suggest a date, but this one we don't have yet. If available only. Next one. Next slide. We can skip this one. This is the graph, but we don't have this graph as well. Next slide. This is the template for reporting. I think we just go through the next slide because I focus on each section individually. This is test, method, sample quality we just added recently because it's of ISO requirement. Clinical notes, date of sample taken is important. Result we have drop down actually, whether you put value only or detected above upper LOQ, detected less than 0.030% or not detected, sufficient ABL copy number. This is the possible IRIS international scale value that we can put there. The next slide. The interpretation, we have a lot of interpretation here. BCR-able fusion transcript is detected at the level of RS value. If it's 6%, we don't have to comment the MR because we don't expect the patient to reach MR3 at 6 months. But if the patient, let's see, 2%, but the patient tested at 12 months, we can comment patient does not achieve MR3. And this patient, if 4% again, but the patient before has achieved MR3, but now MR3 meaning is 0.1% or 0.009%, but now it's 4%. So we just put 4%, patient has lost major molecular response. This one, if this one is 0.01%, consistent with MR3, and this one is detected below limit of detection. This one is detected above LOQ, and this one is detected sufficient ABL copies. Patient has achieved MR 4.5. These are the possible interpretation. We just do this drop down so that we don't have to think it every time we need to interpret. Next slide. This is comment that we add. suggestion, technical verification, and reported. The next one, next slide. This is a note, this is a must actually appear in all report essays, specifically detect and quantify the P210, E13, E14 BCR-able transcript isoform, not intended for use in diagnostic setting as it does not detect all BCR-able mRNA fusion forms. The analytical sensitivity of this assay has been determined at 0.0032% RS, which is MR 4.52. This assay is reported using international scale in which 0.01% is considered as major molecular response, 0.0% as MR4 and 0.0032% as MR4.5. This is wajib. Every report has this, need to have this disclaimer notes. Next slide. This is an example of the report. I think this is the value, 0.062%. And this is the interpretation. These are able. Transcript is detected at the level of 0.062%, consistent with MR4. Next slide. I think you can go through later. Next slide. For the purpose of this webinar, actually, for the purpose of the 5 hospital, this is for training and competency. And we have the webinar now. And hands-on training as like SPDM will go to each hospital. For the one, these 5 hospital, I'm going to email the exercise and the answer for the interpretation. And after that, once you are happy, I'm going to email the competency test as well. And after once you pass the competency test, you can report under supervision at least minimum 10 cases. After that, we can issue competency letter. Because there are so many hospitals, now we have anak angkat, projek anak angkat ya. HTJ is anak angkat kepada Hospital Melaka. So person in charge is Dr. Azlinda, Hoshas, and HRPB is under me, HTA. So I will be in charge for the reporting. I will supervise the reporting. Hospital Sultanah Bahia will be under HPP. Dr. Ayuni is in charge. SUS is under JB. Dr. Wee is supervising Dr. Lai reporting the result at the moment. And if there's any problem, we can always discuss. The next one, then if any doubt, we have networking. It's so simple, nothing complex, just WhatsApp group. What we do is standardization in reporting, discuss any difficult cases, any problem, if there any new information. And the other thing is the important one is a QA performance. We're going to share the link there, and it will be monitored by Jawatankuasa Molecular Hemato-Oncology. And if there's any problem, we can always contact Sean, application specialist, for any troubleshooting or anything that we cannot resolve. And I think before this is my references. And Doctor, actually, thank you. But before I stop, actually, Dr. Rauda just mentioned about the verification. For the verification, how are you going to do it for the verification? At least you have to do the MMQCI C130RS panel. This is the one that we did. It has the 6 level of the BCR-able. We have to do that so that we are sure that our machine, our platform can give result accordingly to the at each level, especially at the critical level 0.1%, 1%, 0.003%. We have to verify that our machine is performing well. Only then we can do at least 2 samples for verification. You can send to HTA, you can send to HSA, or if you want to compare with different method, you can always lies with Ampang, is up to you. But for us, HTA, we just compare with each, because we I think Melaka compare with HTA. And for the EQA, I think it can be ongoing because once you have EQA result, you can add on later, because we cannot do everything in one go. If you have money, it's okay, you can do EQA as part of your verification. But if you are tight, I think you can always at least do the two samples, the control with the 6 levels, and do the two patient samples if are okay, and you are ready to start the service. And provided and the training is here, and then for reporting you don't have to worry, because the 10 first cases is going to be reported under supervision of this pakar lah. And with that, I thank you.
Okay, thank you, Dr. Siti Shahrul. Okay, last but not least, I would like to invite Dr. Wee Xiang Hui for case discussion. Dr. Wee is currently a pathologist in hematology at the Department of Pathology, Hospital Sultanah Aminah, Johor Bahru. She graduated from Royal College of Medicine, Perak in 2009 and obtained her master degree in pathology from UKM in 2019. So, Dr. Wee, you may share your slides.
Can you hear me? Okay, good morning. I'm Wee from Hospital Sultanah Aminah, Johor Bahru. So I will be presenting a few cases that to let us know that how to report the BCR ABL qualification. Okay, so for the overview, when we receive the BCR ABL1 result, we want to determine if the BCR ABL1 P21 fusion transcript is detected or not detected. So if the result come out as not detected and there is sufficient ABL copies, meaning the ABL CT value is less than 18, equivalent to at least 32,000 copy numbers, we can report as BCR ABL1 P21 fusion transcript is not detected with sufficient ABL copies and patient has achieved PLN MR 4.5. If the result come back as detected, is it clear or is it breaking?
Hi, B is a little bit breaking.
A little bit breaking, huh?
Your voice is quite soft.
Oh, yeah. How about now? Is it better? Is it still the same?
Can you speak again?
Okay. Is it clear? Or is it still soft?
Yeah, now it's clearer.
Now it's clearer. Okay. Okay.
Now it's
So
clearer.
now it is clearer. Okay. So if the BCR ABL1 is detected, we want to see if the patient has achieved at least MR3 or not achieving MR3. So if the patient has achieved MR3, there are two situations. It may come out as a IS value given, or the value is too low, that is below limit of detection. So if the IS value is given, we will report as BCR ABL1 P21 fusion transcript is detected at the level of how much IS, percentage IS, consistent with MR how much. So the MR here will refer to the ELN MR, which are MR3, MR4 or MR5, 4.5, sorry. So if the value is below limit of detection, we will report as BCR ABL1 P21 zero fusion transcript detected at less than 0.0030% IS, below limit of detection, patient has achieved MR 4.5. Okay, so if the patient will not achieve MR3, we want to see if there are two situations also. Either the IS value is given or the value is too high, which are above upper limit of quantitation. So if the value is given, if the value is above upper limit of quantitation, So we can report as BCR ABL1 P21 fusion transcript is detected above upper LOQ more than 55% IS. If the value is given, we will see if the patient has been on a TKI for at least 1 year or less than 1 year. So if the patient is less than 1 year, we do not expect the patient to achieve MR3 yet. So we can just give a simple statement or how many percent IS is detected. And if the patient has been on TKI for at least 1 year, we have to see if previously patient has achieved MR3 or previously also did not achieve MR3. If patient previously did not achieve MR3, we just report as BCR ABL1 P21 fusion transcript is detected at how many percent, and the patient do not achieve MR3. But if patient previously has achieved MR3 but currently has lost MR3, so we need to highlight that patient has lost major molecular response MR3. Okay, this is the overview of our reporting. So now we will look at the cases. So the first cases is a 35 years old Malay male diagnosed CML-CP in April 2020 on imatinib since May 2020. Last PCR ABL1 quantitation was at 0.0305% IS. So this is the result that will be printed from the analyzer. So from here, this is the IRIS international scale percentage, and this is the MR calculated by the analyzer. Okay, so for under the result, we will report the IS percentage and also the calculated MR. Okay, so from here, we can see that 0.034% IS is less than 0.1%, but not as low as 0.01%. So currently, patient has achieved MR3. You can also see from here, the calculated MR is 3.47. So we will choose this statement. So the final interpretation will be BCR ABL1 P21 fusion transcript is detected at the level of 0.034% IS, consistent with MR3. Okay, so for the second case, this is a 27 years old female diagnosed CML in December 2019 on imatinib since January 2020. Last BCR ABL1 quantitation was 0.0157% IS. So currently, the BCR ABL1 is detected. The IRIS IS will be 0.0036 and calculated MR is 4.44. So theory-wise, 0.0036% IS is less than 0.01%, but not as low as 0.0032%. So currently, patient is at ALN MR4. So again, we will choose this statement, and the final interpretation is BCR ABL1 P21 fusion transcript is detected at the level of 0.0036%, consistent with MR4. Okay, for case number 3, 24 years old male diagnosed CML in December 2019 on inotinib since 5th of January 2020. Last PCR ABL1 quantitation was 0.0046% IS. So currently, the PCR ABL1 is detected, but below limit of detection. So this is how we report under result. So IRIS IS, we will put that detected at less than 0.0030%, IS below limit of detection, below LOD. So calculated MR will be more than MR 4.52. Just follow the statement here. Okay, so from here it will be easier. So we will just choose this statement. Okay, so BCR ABL1 P21 fusion transcript is detected as less than 0.0030% IS below limit of detection. Patient has achieved MR 4.5. Okay, so for the next case, 23 years old female CML-CP diagnosed in January 2008 on imatinib 400 mg started since March 2008. Last BCR ABL1 quantitation was below LOD. So from here, we can see that it's negative, which means BCR ABL1 is not detected with sufficient ABL transcript. Okay, so for result, we will put for under IRIS IS not detected, sufficient ABL copies. And calculated MR don't need to put as it is negative. So from here, we can choose this statement. Okay, for interpretation. BCR ABL1 P21 fusion transcript is not detected with sufficient ABL copies. Patient has achieved MR 4.5. Okay, so case number 5. 18 years old male diagnosed CML in December 2019 on imatinib. Last BCR ABL1 quantitation was at 0.0036%, MR 4.0. So currently, patient the BCR ABL1 is detected, but below the limit of detection. Okay, so for the result, we will report the IRIS IS detected as less than 0.0030% IS below LOD, and calculated MR is more than MR 4.52. So for the interpretation, we will choose the statement BCR ABL1 P21 fusion transcript is detected as less than 0.0030% IS below LOD. Patient has achieved MR 4.5. Okay, case number 6. A 21 years old male, CML chronic phase diagnosed in January 2023 on imatinib 400 mg since February 2023. Last BCR ABL1 quantitation was 0.056% IS. So currently, it is detected at 0.0068%, and the calculated MR is MR 4.17. So from here, we will choose this statement. Okay, BCR ABL1 P21 fusion transcript is detected at the level of 0.0068%, consistent with MR4. Okay, now we will see 3 different scenarios where the patient does not achieve MR3. So for this case, 57 years old female, CML CP diagnosed in January 2023 on imatinib started since February 2023, already more than 1 year on treatment. And the last BCR ABL1 quantitation was 1.9%. Okay. So from here, we will report the value as usual. And now we have to see that the patient has already been on treatment for more than 1 year. So we will see how was the previous BCR ABL level. Has the patient achieved MR3 before this or not? So from here, we see that patient did not achieve MR3 previously. So we will choose this statement. Okay, patient does not achieve MR3. BCR ABL1 P21 fusion transcript is detected at the level of 0.62% IS. Patient does not achieve MR3. So for the next case, this is a 18 years old female, CML CP diagnosed in July 2023 on imatinib started since August 2023, still less than 1 year on treatment. Okay. So if the patient currently still less than 1 year on treatment, we do not expect the patient to reach MR3 yet. So we just mention the value. Okay. No need to comment further. Okay, BCR ABL1 P21 fusion transcript is detected at the level of 0.62% IS. Okay, so for the next case, 29 years old male, CML CP diagnosed in June 2018 on imatinib since July 2018. Last BCR ABL1 quantitation was 0.01% MR3. Okay, so now we know that this patient has been on treatment for more than 1 year, and when we look back, the patient has actually previously achieved MR3, but currently has lost the MR3. So we need to highlight that the patient has lost a major molecular response. Okay, so for case number 10, 27 years old female diagnosed CML in September 2019 on imatinib since April 2020. Okay, so now we can see that the result is not detected with sufficient ABL transcript. Okay, so the result for IRIS-IS will be reported as not detected, sufficient ABL copies. And the statement will be BCR ABL1 P2-1 fusion transcript is not detected, sufficient ABL copies, patient has achieved MR 4.5. The next case, a 63 years old female CML CP diagnosed in September 2019, resistant to imatinib, changed to nilotinib since January 2023. So we can see the last BCR ABL1 quantitation was 15.3468% IS. So currently the result has come back as positive, but there's improvement in the patient's treatment response. Okay, so the IRIS-IS and calculated MR value will be put as given. So from here we see that patient has is currently MR3. Okay. Okay, so this is the last case. 23 years old female CML CP diagnosed in January 2018 on imatinib 400 mg started since February 2018. The last BCR ABL quantitation was 46.234% IS. So here the value this BCR ABL1 is detected but is above the upper LOQ. So how we report? For the IRIS-IS, we will put there detected above upper LOQ more than 50% IS. So we don't need to put the calculated MR. So from the statement here, we can choose this. BCR ABL1 P2-1 fusion transcript is detected above upper LOQ more than 55% IS. Okay, so just an example of invalid results we may encounter in the lab. So one thing is that the probe check result is passed. That means this is the invalid result is not due to the probe check issues. So the possible causes are endogenous control ABL failure, which can be seen in poor sample quality, RT-PCR inhibition, or the ABL CT value is more than 18, or the endpoint is less than 200. Okay. So for this one, suggestion is to check the sample quality, whether the specimen storage time has exceeded the duration and temperature recommended that did cause the sample deterioration. Okay, and then you can repeat the test with the original specimen or from the routine lysate using a new cartridge. Okay, another possible cause is that the sample contain excess BCR ABL and or ABL transcript. That means the CT value is less than 8. So you can try to repeat the test with original specimen if available from routine lysate using a new cartridge. Okay, so these are the examples. So if as we can see here, if the ABL CT value is less than 8, you will fail. Okay, BCR ABL CT value less than 8 also invalid. So the result will come out as invalid, too high BCR ABL and ABL transcript. Okay, if the ABL CT value is less than 8, it is failed. Even though the BCR ABL1 CT value is acceptable, it will still come out as invalid because there's a too high ABL transcript. So if the ABL values is the CT value is more than 8, is passed. But for the BCR ABL, the CT value is less than 7.9, so it is invalid because of too high BCR ABL transcript. Okay, so other example is the ABL CT value is more than 18. So it is failed because of insufficient ABL transcript. Okay, this is the same. So for the ABL city value, it need to be between 8 and 18. Okay, so just note that shaking or dropping the cartridge after opening the cartridge lid may also yield invalid results. Okay, if there is if the invalid result is due to poor sample quality, or if there is a persistent invalid result after repeating the test, then we need to test with a new sample. So we will comment as invalid, suggest to send new sample if clinically indicated. Okay, that's for my presentation. Thank you.
Okay, thank you, Dr. Wee. And thank you all our speakers for today. For the recordings and the slides will be shared in the Himato portals for future references once we have the green light from our speakers. And we shall now open for Q&A session. I saw there's one question from Razan Hayati Zulkifli to Mr. Sean. She asked, does Genexpert able to notify the user if RNA quality is poor? If yes, how is the notification given to user? I think Mr. Sean also replied that you would not be able to know the RNA quality is good or bad. Thus, it is recommended to maintain the sample integrity as good as possible. So, is there any other question from the floor? You might turn on your mic.
Dr. Koh, can I add a few
Yes.
things about the reporting? During our discussion, we mentioned about the calculated MR, but for our report, actually, we don't have to include in our final report. In HTA, we do put in our LRS, but this is hidden. When it's in the final report, we only have the RS international value, MR calculated MR for our reference only, and we interpret according to MR because molecular response, it doesn't have the point 3.2 because it's only have 3, 4 and 4.5. If we put the calculated MR, before this we put calculated MR, and clinician is not happy because it doesn't make any difference to them. They don't want to know anything that is more that is not helpful for them basically. So we report the RS value and we report the MR according to our interpretation. So we hide the calculated MR. It's just a guide for us to give our MR as the interpretation. And for the RNA quality is my experience lah. We cannot do the other thing for RNA quality. If we can test the RNA quality if we do RNA extraction separately, but for this one, because RNA extraction and everything is done under the same setting, we cannot do. But the thing is, if the RNA is not good, you won't be able to achieve BCR copy number. And BCR copy number, if it's less 32,000, which is sensitivity 4.5, the result is invalid. So in a way, your sample is good enough to give a copy number of more than 32,000 of the ABL. So if it's less than that, result is not valid.
Okay, thank you, Dr. Siti Sharum. Any question from the floor? Okay, looks like there's no question. Everything is crystal clear. So if there's no further question, then we shall end our session for today. And then kindly fill in the